Good evening, BDO family, and thank you so much for joining us this evening. My name is Jade Curtis, and I am the executive editor of BlackDoctor.org. Please join me in welcoming Dr. Ifeoma Udo, Executive Vice President of Policy, Advocacy, and Science at Black Women's Health Imperative, and Senator Sylvia Santana from Michigan for a conversation on how to fix 340B accountability to ensure the program benefits those it was originally intended for. Ladies, I appreciate the two of you for taking the time to connect with the BDO community tonight. Tonight's
Happy to be here.
conversation, of course, tonight's conversation is a call for change and reform, not blame. The 340B program was designed many years ago to help those in need. However, its expansion beyond its original scope has led to confusion due to ambiguity and lack of accountability. In alignment with our mission, BlackDoctor.org is raising a sense of urgency to reconsider advancing Senate Bill 1179, as it could unintentionally create further barriers for the Black community to access the care they deserve. Again, ladies, thank you so much for joining me this evening. So let's go ahead and dive in. Dr. Ifeoma, I want to start with you. What is the original purpose and intent of 340B program, and how was it intended to support communities of color?
Thank you for the conversation. Thank you for the opportunity. It's a pleasure to be here with the Senator. And let me start off by saying that the 340B drug pricing program, the original intent of that when it was founded in 1992 as a federal policy was meant to support the safety net of healthcare in the United States, particularly for disenfranchised communities who had low access to healthcare insurance, no access to healthcare insurance, whose medications were expensive. A lot of the framing for that original policy comes out of the original intent, quite honestly, came out of the HIV movement, where we knew that HIV medications were really expensive for communities of color to access. The Ryan White programming and what that has done to sort of predicate the 340B policy has been profoundly important. So I think that there's enough jurisdiction there for us to talk about what that means. But 340B was founded in 1992 to allow pharmaceutical companies to provide reduced medications to health providers, hospital systems, federally qualified health centers, clinics, so that they could then pass on those savings to their constituents who also had challenges accessing reduced medication. So it's meant to support healthcare. It's not meant to support big business and hospital systems. And I think that's really important for us to recognize in terms of what the original intent was set out to do in 1992.
Absolutely. And so I understand that the number of 340B contract pharmacies have increased by 8,000%. But with this growth, it hasn't benefited all the underserved communities it was intended for. So do we know why the program is failing to address the health inequities in those communities?
It's a really great question. Again, you're spot on about noting the fact that there's been this broad and wide scale access to pharmacies that have been using the 340B program, but the original intent of the program was to provide those drug discounts back into communities so that those communities then could use the funding that came out of those discounts to support other programs that were existing in their areas that needed to buttress community health care. So anything from having and increasing social workers in your community health clinics to navigate patients through care, through transportation costs, through having community health-based clinics like FQHCs have internal pharmacies that are housed in the clinic site so that patients, when they're in their services, don't have to leave to go someplace else to go find their medication. The idea that those funds were meant to sort of really create robust systems of wraparound care. That's what the intent of the 340B drug pricing. Like, let's put these discounts that we get from pharmaceutical companies back into systems of care. And the reason why that's not happening is a lack of accountability and transparency. That's it. It's a 30-year-old program, and it's not been monitored very well since it was initiated. And it is a federal process. It is a federal public health program that we believe has the ability to create equity. But quite honestly, there's not enough people paying attention to it. And I think that transparency in the process is what's really important to consider when we talk about 340B reforms. FQHCs, federally qualified health clinics, are the only ones that have to report what they are doing with their drug-reduced programs, what they're doing with the funds from their drug-reduced programs. Private hospitals and healthcare providers who are private, or private pharmacies, don't have to report to the federal government the same way that public hospitals have. That needs to change.
Absolutely. And it sounds like that's something that we need to collectively address and ask for accountability, ask questions, and measure where the 340B is going, correct?
Correct. We need to know where those funds are going, they're being used for. Are they going back into community service? What percentage of those funds are going back into community service versus back into hospital care systems? All of those questions need to be asked as a part of the accountability process.
Absolutely. I actually saw in a New York Times investigation that found that, as you mentioned, some of the hospitals have been using the 340B kind of loopholes to prioritize the profits over patient care, which is what you mentioned with some of the private hospitals not having to, be transparent about what they're doing with the funds. And this can be a question for Senator Santana or Dr. Ifeoma. What lessons can Michigan learn from these examples, and how can reform prevent similar outcomes here?
Yeah, thank you for the question. I think that, right now we are in our lame duck session here in the Michigan State Capitol, and this particular legislation has come up here in Michigan to codify into law, or our state statute, the ability to expand those dollars for the 340B program. However, I want to be clear, this is a federal issue that we are trying to mitigate here in the state. And I believe that one of the biggest challenges that we foresee is, as the doctor has mentioned, is the transparency around the utilization of those funds to go back into communities that are underrepresented or that require that support. Here in the state of Michigan, we have 70% of the people who are Medicaid recipients. And so when I think about our hospital systems here, which the majority of those hospital systems are nonprofits, I do believe that the opportunity exists for those dollars to be expended back into the communities where that support is necessary. And so I think that this is not the time to rush legislation through a lame duck session that requires so much attention to transparency and accountability for those dollars going back into those communities.
Absolutely. Dr. Ifeoma, anything to add?
I think the senator is absolutely correct. It's fascinating to me, quite honestly, that this has become such an important issue at this time. I think the time is really fascinating. I also think that there are a number of us who have been advocating for reforms to healthcare provisions like these that are meant to create space of equity in our federal government are actually now being raised at a state level. And I think it's important that the states are paying attention to this because it benefits It does benefit your clients and it benefits your and users of healthcare systems at the state level. But this issue of where do the funds that are saved as a part of 340B transparency, right? So pharmaceutical companies provide discounted medications, and then those discounted medications are supposed to trickle down to our patients and and people who are in need of certain funds from that are also supposed to go back into care systems. They're not supposed to go back into hospital systems for administration or other support.
Mhm.
Where's the accountability and the report and the reportability standards around that? And I think what the senator is implying, and I hope I'm saying that correctly, is that we need we need more time to like document that, particularly at a state level, so that it can reflect what the policy really truly should. So.
Yeah, absolutely, doctor. I think you hit it the nail on the head when you said the transparency and metrics process. We know that our federally qualified health centers through HRSA are reporting how those dollars are going back into systems of care in the community. And I think that when you look at the many legislatures across the country that have put in policies to make sure that pharmaceutical industries are transparent and accountable, I just think this is fair and equitable to make sure that those dollars are going back into systems of care from the hospital standpoints as well, not into their operation costs. Moreover, you have circumstances where those dollars are not going back into urban centers or communities where it's necessary, as far as just access to care. And you see those dollars going into more affluential communities, if you will, to build out, bigger hospital systems. And so I think it's important from our legislature that we take time to deliberate on this issue a little further versus rushing this through this process. And so I think that's what's more important. Yes, we do have hospital systems in rural areas that are struggling, to stay afloat, to continue to provide services in communities. And I think that if we can put some more transparency around how these policies or this particular legislation will help to support that, and that transparency will be very important to making sure that, as we said before, that it's going back into those systems of care. We have here in Michigan, Reverend Sheffield, who has provided an article through Bridge Magazine to talk more about how we need to prioritize or underserved communities, as he runs a community-based health center to help support our communities in my district as well, because it sits in my district. But I think that's important to look from the Black community's perspective at the risk of not having that access to care, because those dollars are not being put back into the systems where they should be, is also something that's relevant to this conversation. How do we get more people in communities that don't have that access to care because of transportation issues, because of other issues, the ability to be able to access those systems? I remember there was a time where you could probably go on a commercial corridor and find in your community and find some type of, small clinic to support you. I grew up in Ohio in a small community called Lincoln Heights, where my primary care physician was from that Black community. And so I think it's relevant to this conversation of making sure the resources go where they need to be.
Absolutely.
I
totally.
absolutely agree with you.
Yeah.
No, I was just say I agree with you.
Yes. And I love that you mentioned that a lot of these programs are in the more affluent communities, and less than 30% of them are in the underserved areas. Excuse me, couldn't get that word out, in Michigan. So how do we address some of those disparities? Because you mentioned some things like transportation can be some of those issues with access, but how do we address those disparities to ensure the program aligns with its original mission to improve health equity?
I want to defer to the senator in terms of those recommendations directly for her state because she knows what her community needs. We work with a number of partners nationally. One of our partners that we work with, Bishop Marcia, oh my gosh, for Black Women from Change is someone that we work very closely with who's expressed her concern around this and has talked about Bishop Marcia Dinkins, has talked about her desire to ensure that SB 1179 doesn't get sort of swept under the rug. But I want to defer the senator for her thoughts on how this works in her own state.
So thank you. For me, I have been on the Health and Human Service budget since I came to the legislature, and I will say to you that even as a representative, being out in the community, seeing where people did not have access to dental care was just eye-opening. Seeing how Hep A was an issue in Detroit. These are all issues that are, and the issues being so prevalent when it comes to disease in our community, whether it be hypertension, diabetes. We're on all of the worst lists when it comes to healthcare, but the top list when it comes to other areas that we should be higher, like as far as education and attainment and things of that nature. But when it comes to healthcare, the Black community is struggling when it comes to healthcare. And so one of the things that, I would say that we've done as a state is focus on making sure that we have mobile units that can get to people in communities around our state, because access to transportation is so difficult for a lot of people to get to the healthcare facilities. I think one of the things that was daunting to me around the federally qualified health centers in our state, we have not given them a raise as far as their rates, Medicaid rates, in over 14 years.
Wow.
Me being the chair of the Health and Human Service budget, this just happened this past year. And so when I think about these dollars that could be going more into our federally qualified health centers, not to say that the hospitals are not deserving of continue to support our communities, but I think that when I think about the 1,500 FQHCs that we have in our communities across Michigan, my priority is making sure that those resources get to them first and foremost, because I know that they have the transparency and accountability for making sure that they're doing the right thing. And so I think that's what is most important, is making sure that if the hospitals are going to continue to receive these dollars, that it's not just a 2% of the dollars that are being utilized towards continuum of care in our communities. I think that's something that really needs to be reflected. I think that only 80% of those dollars should be going back into care resources. Only 20% should really go into any additional ancillary or operational costs for the hospitals. So I think these are things that are really important to making sound legislation, making sure there's transparency, making sure we can see where the dollars are going. That's really important for all of us. Matrix, the hospital systems, all systems deal with matrix and accountability. And I think that we should hold them to that. And I think that's just really important. If I can see as a state lawmaker that you're spending these dollars back into the communities, that lets me know when I'm looking at the Health and Human Service budget that I'm going to see healthcare disparities go down. I'm going to see maternal health, women making their dates for their pregnancy instead of us having a lot of situations where people are not making their dates for their pregnancy. That's going to change. We're going to see those changes because we know those dollars are impacting these issues that statistically are bad for our state. And so I think that's really important.
Absolutely. And, as you mentioned at the top of the show, even though to our audience, even though we are talking to the senator of Michigan and speaking on Michigan issues specifically in Michigan, this is a federal issue. And so I want to ask the two of you, for those who are watching, who want to use their voice, how should they use their voice? And what can people in the community do who want to see those changes, who are paying attention and realizing, okay, there is money out there. What can be done? How can we make sure that that money gets to the right places?
Yeah, it's a great question. Again, I'm always going to defer to the senator for how she wants to address these issues at her state at a federal level. I think it's really profoundly important as we move into 2025 with a new Congress, a new designation around how we're thinking about these issues, that we really encourage folks to understand what 340B is in the relationship of the wider scale opportunities for public health access, Medicare access, care access. I think it's really fascinating that a lot of people didn't even know that this existed. So I think that the continuum of keeping to talk about it at our community-based levels with our constituents. Again, Marcia Dinkins is a partner of ours at BWHI. We've been talking about 340B with everyone we can get our hands on to say, hey, y'all should know about this. This is actually one of those like big federal public health programs that has billions and billions of dollars attached to it that could impact care, and no one even knows about it in their states, right? So as much as we can do to educate the public about this, whether or not it be in your community-based groups, your panel presentations as this, all the conversations that we can have. I think we can to ensure that we have advocates at our coalition tables who are pushing this issue as intersectional, right? This is an intersectional issue, again, related to drug costs, related to healthcare access. And so if you're at the tables talking about Medicaid or the ACA, then right alongside that, 340B is an important conversation to include as a part of that, because you can't separate them in terms of patient access and patient availability to access care. Medical debt is really impacted by this legislation. People who are struggling with medical debt and who haven't been able to afford their medications. It's a very intersectional conversation. So I think wherever it is that you can push the envelope, whether or not it's at your community-based groups, your coalition groups, your chapter meetings, your health advisory boards, within your own policy-based organizations that are addressing this issue, and to not separate it out as something different from Medicaid or ACA. It's actually supposed to work concurrently with those issues, and I think that's a really big piece of work that we have to do.
Yeah, I agree with you. I think one of the things I always tell my constituency is that your vote matters, but also your testimonial and your advocacy for policies that come up in the legislature are also important, that you are giving your own stories around how either, this has helped you as far as your own testimonials, or how, you could have used a program like 340B to help you to have more month than money when you were trying to decide between buying your prescription drugs and buying groceries for the month.
Yeah.
These are all real conversations in my community where, I try to uplift these issues for the community. And so I think it's important to continue to have stakeholders at the table to talk about these issues. We have coffee hours in our state regularly from a legislative standpoint to make sure that we continue to connect to our community organizations and our constituency. And I think that educating the community on this. I put a post out on my Facebook just so that people could participate in this conversation today and understand why this is so relevant to our community, because when you have 4 of the top poverty zip codes in the state of Michigan, it's relevant. And so I think that as we continue to push policy here in the state, we have to be deliberative about how we are showing up as lawmakers and how we are advocating for these issues. And I think our constituency deserves that. We work for them. They don't work for us. And so educating the community is a huge part of that. And what I like to say is keep it simple, stupid. So what I try to do, Doctor, is find analogies that people can understand, that they can understand from a very non-technical standpoint, so that they get it. And that's really important to making sure that they can understand the policy that we're trying to make sure that we uplift here in the state of Michigan.
Absolutely, Senator. The stories matter. The stories matter. And we know that there are people on the ground who are in deep pain and are frustrated and are scared and can't figure out how to access their health care, and they don't know how to about it, and they don't even know that there are resources available to them to do that through this program. The stories matter.
Absolutely. And you talked a little bit, and I don't want to, I hope I'm not talking out of turn, but you talked a little bit about medical debt. And, it has me thinking about this past appropriation that we did here in the state of Michigan to try to reduce our medical debt. The state of Michigan had about $80 million total in medical debt as far as uncompensated care. And so I think to myself, well, could 340B's program have supported some of that uncompensated care versus what, us, versus the dollars that have come into the state for a program like 340B? Could we have taken those general fund dollars and utilized them for something else, had 340B dollars been transparent and utilized for that medical debt relief? So those are things that I think about as a state lawmaker when it comes to intentionality and the decisions that we make here at the state. And it's important. Yeah, absolutely.
That's right.
Absolutely. Thank you, ladies, for that. Senator Santana, I want to dive in a little bit more into the legislature. There's a plan being considered by the state legislator, Senate Bill 1179, to alter the federal 340B program. The bill, while well-intended, oversimplifies the complex issues surrounding 340B, which can potentially cause compounding existing inefficiencies. So what are your thoughts on the bill? Do you oppose? And why do you feel that way?
I think that, obviously the bill as it currently stands is not going to help support any changes to actually do what 340B is intended to do. What this would allow for is just an expansion of continuing to provide the hospitals and others with an expansion of dollars to the state, which would still continue to do what it currently is doing, which is helping to uplift their operation budgets. And I think that we have to have more transparency around those dollars in order to make sure, like I said before, that they're going back into care. And so I think we need to really kind of take a deep dive into this before we continue to move forward on this policy. To answer your question, I think also that because the legislation is being rushed, it did not make it through the Senate House committee. They did have a hearing on this policy, and there was a lot of concerns from the House members around this policy, and hospitals are not being very transparent on how those dollars are being expended. I think that we should not rush this through the lame duck session.
Gotcha. Dr. Ifeoma, any thoughts to share?
I agree with the senator. I think 11 is not clear yet in terms of its intentionality around where the use of the funds will go from the discounts, right? And that's a big part of what we've been discussing and promoting and pushing and advocating for. at BWHI is this level of transparency. There's where do the funds go, and how do they get used, and how do they get used specifically to buttress and support the safety net for healthcare. Right now, my understanding, and Senator, you might need to correct me on this, is that there's a lot of, I took some notes. I was trying to prepare myself.
Yes.
I took some notes that the contract pharmacies, the intent of the 1179 is to make it enshrined that contract pharmacies are the only ones that can access the benefits from 340 pharmacy. And you might need to correct me on the language and the terminology around that, but I want to be clear that contract pharmacies are not the only way to support broader scale access to healthcare. And so if you only keep the intended benefit for the drug discounts in that sector, it leaves out a whole entire sector of public health pharmacies, of FQHCs. It doesn't make it clear on where those funds get to lie. And I think that is a thready rope to walk when we talk about who gets access to the use of the 340B benefits. So
yeah, absolutely. You're absolutely right. And I believe that those reforms should actually prioritize more access to, making sure that we're improving access to prescription drugs, not taking away from it.
Correct.
And I think that, that's one of the biggest things that we need to amplify here is the purpose of the whole 340B program in its original intent. And I think that we have to close those loopholes in order to make that happen. There has been conversations at the federal level around a task force through our U.S. Senator, Debbie Stabenow, and others to work on fixing this issue at the federal level. But there's still, have to make progress on it. But as you said before, we are changing of administrations and also through the House and the Senate. And so there will be challenges there. So I'm not opposed to fixing this on the state level. I think we need to fix it in the interim of being able to do it at the federal level. But we need to make sure that the intent to make sure we shouldn't be minimizing the ability for others outside of the contract pharmacists to be able to be supported. I've seen far too often in the state of Michigan where we have contracts that are limiting expansion to the individuals who are right here in our state providing services for many plus years, Black-owned businesses who are providing optical support to our communities right in the heart of Detroit, who can't even get, a piece of a contractual agreement here from our health plans. To bring that up, I know that's a separate issue, but that's just an example of why we don't need to just go with contracted pharmacists here in state. Then you're picking winners and losers, and instead of the intent of the program, which is to make sure that you're having expansion to care. And as you said before, if we're not educating our communities on this program with the ACA, with other programs that are out here for our communities, then that access is limited, and we should not be doing that whatsoever.
Yeah. I hope I stated the purpose of 1170 correctly, because I like I said, I just studied up on it right before this call, and I was like, oh, this is not right. So yes.
Yes, absolutely. And I'm glad you mentioned, some of the programs that could benefit from this program. But I'm also curious, and while BDO does stand on the stance of reform and change versus blame, have you seen examples of groups taking advantage of the 340B program and taking profits at the patient's expense?
I think you can look across the country and see that. I don't think you necessarily have to designate that towards Michigan. I mean, last year alone, I believe this program, the cost was over $54 billion. Like that's what it be. And only 2% of those dollars actually went into supporting actual continual care. And I think that's unfortunate. So we have to, obviously do things differently. And I think when you look at states like North Carolina, they really have modeled this legislation in a way that makes sure that the discounted acquisition cost goes to who it needs to go to. And I think that's important as well, that we make sure that the dollars are going back to where they should be going. And when you look at the amendments that we're trying to provide with the 80-20 split, I think that's really relevant to making sure that the resources are going back to where they need to. 2% is abysmal. That means 98% of the dollars of that 54 billion did not go to where it needed to go. Yeah. And so I think that's really important to uplift that.
Absolutely. And due to transparency, I guess we don't know. We'll never have a true answer of what really happened. And so I guess I'm curious, what type of changes do you suggest need to be made to get those resources to the communities the program is intended to serve?
I think like I said before, I think the federally qualified health centers that haven't had an increase till this last year that I, with my colleagues helped to support, they need those dollars. They're already required to provide that transparency. And so I think that's where we need to stick those dollars. Our public health centers, we need to stick those dollars there. People know that they can go to their public health center to get those supports. I think that's really relevant, making sure that we're meeting the expectations of our community right where they're at. And I think that's important to be able to designate those dollars towards where the accountability is already existing. And when you look at the federally qualified health centers, they already have those programs in place. When it comes to our hospitals, I think they need to they say that they already are reporting to HRSA, but that is not true. And we have a significant amount of, and I'm not doing blame, I'm just saying what's real. We have a significant amount of nonprofit hospitals in the state, but we need to make sure that transparency is visible and that those matrix are available and show pay. I know that for HIPAA, we cannot go into people's medical records to say who they are and how they're receiving the services, but there should be some accountability there to show and reflect, whether they come from a community that is in despair, or they come from a zip code like mine, the 5 top poverty zip codes in the state. If they come from my community, we should be able to reflect that information based off of that zip code correspondence or demographics. And so I think that is really important to making sure that there is accountability. And I think there's other steps and measures we can take. But let's not rush this through lame duck. Let's do this right, so that, if it doesn't happen at the federal level, that at least it's fair and it's equitable, and we know that those resources are going where they should.
Yeah, absolutely. Agreed.
Absolutely. And you recently mentioned in your previous response, North Carolina and the program that they have. And I want to talk a little bit about what they've done. So this past May, the North Carolina State Treasurer released a report finding that 340B hospitals billed state employees an average price markup of 5.4 times their discounted acquisition cost for oncology drugs. And within the last month, the Minnesota Department of Health released its report that exposes how some nonprofit hospitals and clinics in Minnesota abuse the 340B program to mark up medicines while bringing in $630 million in profits. Is there a way that a similar study could be ordered by Michigan legislators?
Absolutely. I think, we should take the opportunity to at least gather information and provide a work group to support being able to, really reconcile what's real versus what's not. And I think that's important to make sure that we do this right. One of the things that, I asked for, because I'm a finance person, so I'm a numbers cruncher. So one of the things I asked the hospital for, give me the numbers, show me the information, show me how these dollars are reflecting back to where you say they are going. And it was abysmal what I received. And so I want to be able to work with our hospitals, with our public health facilities, which we also funded in this last budget to make sure that they can continue to have those resources. But I want to work with the providers that are working with us to make sure that we are getting down these numbers in our state when it comes to disparities. It's sad as we sit on a committee and not see numbers go down, or make sure that we are changing the trajectory of our communities. And so I think that it's important that if we're going to be deliberative about legislation, that we have at least all of the data that we can review first to make sure that we're doing this right. And I get it. Some of my colleagues are concerned about the resources to their rural hospitals or their hospitals in general, but I've appropriated dollars towards hospitals in these last several budgets prior, especially during COVID, where we receive additional federal dollars for our state. So a lot of our hospitals have received those dollars. There are opportunities out here for our smaller rural hospitals. We have 7 total in our state. So there are opportunities for those hospitals to work with the congressional our congressional people to receive additional resources or grant dollars to keep them sustained in lieu of us getting this done. So there's opportunities that exist to make sure that we continue to uplift the access to care, which is most important. But I think that we need to really take time to deliberate over this legislation and make sure that a program that was originally designed in 1992 that unfortunately has expanded in the wrong direction can be revamped at the state level to make sure that we are being deliberative about how we're putting this program in place. Other states are, obviously seeing where this is, like you said, North Carolina, 5.4 times they're charging their employees for those drugs. That's unfortunate when they're probably receiving billions of dollars to help support making sure that cost savings is passed back on to their employees. So I think we have to go in the right direction. We have to be deliberative, and we have to make sure that everybody has a seat at the table to talk about the issue. We can't just go to our friends or pick winners and losers. We got to make sure that the access to healthcare is real and that it is reflective.
Absolutely. Well, ladies, I want to thank you so much for joining me this evening. Do you have any final thoughts or any key takeaways you'd like to share with the BDO community? Dr. Ifeoma, I'll start with you.
We are in a new time and a new era in what is moving forward in terms of our country's politics in 2025. Paying attention to what's happening in your local state jurisdictions, your local city jurisdictions is going to be incredibly important. Attention, obviously, to what happens at the federal level is important as well, but how that impacts our homes and our families and how our day-to-day lives work is really happening at the state level. And so I think the credit of this conversation and the credit of Senator Santana in terms of paying attention to this, pay attention to your local constituents, pay attention to the rights and the ways that you want policies to impact your lives at a local level. I think that's incredibly important. And I think for this issue, 340B is important, and a lot of people don't know about it. And so if this is your first time hearing about it, reach out to your public health infrastructure, reach out to your doctors, reach out to your nurses, reach out to your policymakers and ask for more about how this program is supposed to benefit you as a consumer. I think that's incredibly important that we get the word out about this work.
And I would like to just encourage our doctors to also stay engaged on this conversation as well. And also our health clinics and our public health facilities, please stay engaged in the conversation. I probably going to do a town hall in my district here pretty soon, just because I like to bring the knowledge to my community, to make sure that people understand how these policies have adverse effects if they are not put in place in an intentional way. So I will continue to support the effort to making sure that we do this with intentionality and make sure that those resources get to the right people. But I think it's important also for our constituency to really continue to stay engaged. Don't fall asleep on lame duck session or even session throughout the year, because that's
right.
really important. Just because you vote for us doesn't mean that you don't have to do progress reports and accountability checks with your state lawmakers. So even those who may support, there has to be conversations. And I know that keeping it simple for the community is what's most important so that they understand.
Absolutely. Well, thank you, ladies, once again for joining me. Thank you for sharing your expertise and for educating the BDO audience on this very important matter. For those of you watching, please continue to pay attention to your local government and your federal government and the things that are happening within our community and how it impacts yourself and those around you. If it's your first time hearing about 340B, please share it with others. Share this Facebook Live and inform others, because we all need to know. We all need to be a part of the conversation. Again, ladies, thank you so much, and I hope to see you guys soon.
Thank you.
Take care. Thank you.